Hi all, welcome back to the lecture series. In continuation with the ECG lecture series, today in this video I am going to discuss about ECG interpretation. That is, interpretation of a Thorley ECG. Most of the clinicians feel ECG is difficult, some waves, intervals, something which they cannot interpret. But if you follow simple principles and a stepwise approach, you can easily interpret the ECG and make a diagnosis which can be made using an ECG. I am Dr. S. Prakash Babu, Associate Professor of Department of Emergency Medicine at KIMS and RC, Changalpattu. First of all, let's recap some of the points regarding the ECG. As you all know, electrocardiographic paper is thermosensitive. A moving heated stylus records the ECG waves on the ECG paper. The paper is said to move at a constant speed, which is predetermined, that is 25 millimeters per second. So all your graphic representations will have specific time durations and they are calibrated. You all know the time is measured on the x-axis and it is in seconds. Voltage is measured on the y-axis and it is in millivolts. Graph paper is calibrated into 1 mm wide small boxes which are separated by thin lines, and there are 5 mm wide boxes which are separated by thick lines. The 1 mm box is called a small square and the 5 mm box is called a big square while interpreting the ECG or talking about the ECG. So this is a graphical representation of the ECG paper. Here in the x-axis, if you see, it's denoted in time, seconds, and in the y-axis it denotes the amplitude or the voltage. In the x-axis, one small box is equal to 0.04 seconds, while one large box, that is a 5 mm box, is equal to zero point 0.2 seconds. Whereas in the y-axis, one small square is equal to 0.1 millivolts and 5 small squares 0.5 millivolts, 10 squares 10 small squares or 2 large squares is equal to 1 millivolt. That is the standard ECG representation. So this is a representation of a normal ECG, the waves, the intervals and the segments. The first and foremost wave is the P wave, which represents atrial depolarization. The next and most prominent wave in the ECG is called the QRS complex. It represents the ventricular activity. A total ventricular repolarization activity is recorded in the ECG, whereas atrial repolarization activity is not recorded because it is submerged into the ventricular depolarization activity. Most largest prominent positive wave in the QRS complex is the R wave. The prominent negative wave following the R wave in the ECG is the S wave. Q wave is mostly a small wave, which is the first negative wave of the QRS complex. And then the T wave represents the ventricular depolarization. Following the fast phase of the ventricular depolarization, you have a small phase of ventricular depolarization or the after depolarizations, which are usually represented with a small U wave. Most of the time, the U waves are submerged. If the ventricular rate is slow and the QT interval is wide, then you may be able to appreciate the U waves properly. So with this background, let's see a complete segments and the intervals. P wave, this is a P wave, and then you have a small negative deflection in the QRS complex. The first negative deflection in the QRS complex is called the Q wave, and then a larger positive deflection, the R wave, and then there's an S wave. The junction of S wave with the ST segment is called the J point. J point is measurement of ST segment elevation and ST segment depression in most instances. And then coming to the intervals, you have the PR interval, you have the QRS duration, and you have the QT interval. And then you have RR interval and PP interval, which are used for rate calculation. And then there is a TP interval. Coming to the segments, you have the PR segment, which is most commonly used as an isoelectric line. You have an ST segment, which tells you about the ischemia, the muscle status, oxygenation status in the cardiac muscles. And then you have the TP segment, which is the gap between one action potential to the other action potential. Let us look at some of the principles of interpretation of an ECG. You need to follow a systematic approach. You should not falter in your systematic approach. You should not miss or skip any step when you are following a stepwise approach. The rhythm strip is enough to interpret the arrhythmias. You don't have to have a 12-lead ECG to interpret arrhythmias. Either the rhythm strip or the rhythm that is shown on the monitor will be enough for you to interpret any arrhythmias. But if you want to look at more complex ECG abnormalities like electrolyte abnormalities and your ischemia, infarct, you need to have a 12-lead ECG. So first of all, when you take ECG paper into your hand to interpret, you need to look at some of the technical aspects to be sure that the ECG is taken under specific patterns and specific conditions so that the ECG is made readable and the interpretation will be correct. So ECG should be technically correct before assessing it for any abnormalities. Make sure the baseline is free from any electrical interference or drift. If the baseline is moving up and down repeatedly, there is the electrical interference. You will not be able to see for any dips in the PR interval, elevations or depressions in the ST segment. So you should be able to see a isoelectric line, which you normally use as isoelectric line is the PR segment. PR segment should be straight. Look for the lead positioning, which is most common. Commonly, the limb leads are the ones which are misplaced. You know, there are four Frank shaped electrodes. One of them is neutral and three of them will participate in recording the electrical potentials. You know the placement of the leads from the previous lectures. Lead AVR, this the unipolar lead of the limb leads is placed on the left arm. If you remember correctly from the lead placement lecture, this lead is placed on the left arm against the electrical axis. The electrical axis of the heart will be flowing from the SA node to the ventricles. You know that if a lead is, if the electrical activity is approaching a lead, it will record a positive deflection. The electrical activity is moving away from the electrode, it will record a negative deflection. So when you are looking for whether the lead position is correct or not, if the leads are correctly placed, all the waves in lead AVR should be negative. There should not be any positive wave in lead AVR. Right from P wave, QRS complex, and the T wave all should be negative. That means the ECG leads have been placed correctly. And then you need to locate the lead markers. It will have 1, 2, 3, AVF, AVR, AVL, and then V1 to V6. You need to look for the lead markers. If the lead markers are misplaced, then your ECG interpretation is possibly wrong. Check for the standardization markings. Standardization marking is the first lead which shows a 10 mm high and 5 mm wide box. That is the standardization marking. If the ECG is correctly shown as 10 millivolts high and 5 small boxes wide, that is a standardized ECG. And then look for the duration. the speed at which the ECG paper moves, which is given, and the voltage. Next, coming to the assessment steps proper. First and foremost, you need to determine the heart rate and rhythm, which are interrelated. You will know shortly. And then determine the heart's electrical axis. I'm not going to tell you all the details of locating electrical axis exactly, but I'm going to tell you in this lecture a practical approach to know how the electrical axis of the heart is either displaced or is normal. Then you look at the P waves. The first is P wave, QRS complex, T wave, and U wave. Then you look at the intervals and calculate the intervals, whether they are falling within normal limits or abnormal. Calculate the PR interval, QRS duration, and the QT interval. Then proceed on to analyzing the segments, PR segment, ST segment, and sometimes you might need to assess the TP segment also. So for determining regularity, you need to calculate the RR intervals, and if all the RR intervals are same as shown in this picture, the ECG should to be regular. It can also be occasionally irregular, where only one or two of the RR intervals are different from the other RR intervals which are equidistant. Then you say it's occasionally irregular. It can be regularly irregular, where at specific intervals, say every 2 beats there is a widened RR interval, every 3 beats there is a widened RR interval, right? You say that as regularly irregular. Irregularly irregular means no two RR intervals are equal. But practically, if you want to perform and interpret an ECG within 10 minutes, which is a norm for identifying ST segment elevation MI in patients presenting with chest pain, this is a cumbersome process. So what you do is place your ECG on the table, take a white paper and mark the peaks of R waves. And then you first 3 R waves you mark, and then move your piece of paper to the next R wave. If all the peaks of R waves are correlating with your markings on the paper, then the rhythm is said to be regular. Next step is you need to calculate the rate. There are two options to calculate rate. The first and foremost, whether the rhythm is regular or irregular, you can use. What you do is you take a 6-second rhythm strip, that is 30 large boxes. 6-second rhythm strip means 30 large boxes. You count the number of R waves in that 6-second rhythm strip at 30 large boxes. So that gives the heart rate for 6 seconds. But when you are saying heart rate, you are saying for 60 seconds. So multiply that number of R waves with 10, you will get the heart rate approximately. So in the given ECG, there are 1, 2, 3, 4, 5, 6, 7, 8, 9, nearly 10. So there are 10 R waves in the 30 large boxes are 6-second rhythm strip. So multiplied by 10, 10 into 10, 100, or if you want to take this out, 9 into 10, 90 will be the approximate heart rate. This formula can be applied with irrespective of whether the rhythm is regular or irregular. This is the simplest method to calculate the heart rate. But when the rhythm is regular, you can use the RR interval method, which gives more precise calculation of heart rate. You can take RR interval either in large boxes or in small boxes. If you are taking RR interval in the large boxes, divide 300 by number of large boxes that form the RR interval. The given ECG, there are 3 large boxes between 2 R waves everywhere equally. So 300 by 3 gives the heart rate as 100. If you want to calculate more precise rate, You can take small boxes. When you take small boxes between RR intervals, the number of small boxes between RR intervals, you need to divide 1500 by number of small boxes between RR. That gives you the heart rate. In the given ECG, there are 15 small boxes. So 1500 by 1500 is the heart rate. Next step is determination of the axis. As I already told earlier, I am not going to details of locating the exact axis, but I am going to give you a practical way of knowing whether the axis is normal or displaced. For that, you use the quadrant method. You divide into a circle divided into 4 quadrants. The lowermost right quadrant, the lowermost left quadrant, you need to look at lead 1 and AVF, the limb leads. If both lead 1 and AVF are positive, which should be the case in a normal ECG, the axis is said to be normal. If they are reaching each other, that is lead 1 is negative, AVF is positive, the axis is right axis. If they are leaving each other, see, the peaks are leaving each other. That is, lead 1 is positive, whereas lead AVF is negative. The axis is said to be the left axis. If both are negative, then the axis is said to be either indeterminate axis or extreme right axis, which is a very rare event. So you know now you are going to look at lead 1 and lead AVF. If both are positive, the axis is normal. If they are leaving each other, that is lead 1 positive, lead AVF negative, that is left axis. If they are reaching each other, lead 1 is negative, whereas AVF is positive, that is right axis. Next, to look at the P wave, I will give you some of the most important characteristics of P wave. The P wave is a small rounded wave produced by atrial depolarization and represents the sum of the right atrial and the left atrial activity. The initial part of the P wave, the first half of the P wave represents the right atrial activity because the pacemaker, that is SI node, is located in the right atrium, and right atrium is the first to depolarize whenever SI node depolarizes and an impulse is released. And the second half of the P wave represents the left atrium. P wave is normally upright in most of the leads with few exceptions. These exceptions include in lead AVR, as I told already, the whole axis, the whole of the electrical activity is moving away from AVR. So you see an inverted P wave along with inversion of QRS complex on the T wave. In V1, the P wave is generally biphasic. The first part representing the right atrium, which is positive, the second part representing the left atrium, which is negative. Normal P wave is 2.5 small boxes wide and of same height. 2.5 small boxes high. So assessing the P wave, what are the things you need to assess when you are looking for a P wave? First and foremost is you need to look for, are there any P waves? You know, this is a small rounded wave, first positive deflection. The arrows are marked near the P waves. They are the P waves. So in this ECG, the P waves are present. Once P waves are present, whether all the P waves look alike, do they look same morphologically? In this ECG, almost all the P waves look similar in morphology. And then, do the P waves occur at regular rate? Just like RR interval regularity, you need to look for PP interval regularity. So let's see whether PP intervals are regular. Here is the P, 1, 2, 3, about three and of large boxes. There's another P, 1, 2, 3. Again, at about 3.5 large boxes, there is P wave. So the PP interval is regular here. Then is there one P wave before each QRS complex? So 1:1 ratio. SA node depolarizes, the atria first depolarize, and then the electrical impulse is passed on to the ventricles depolarize. Except if there is a hot block, the impulse is blocked from reaching the ventricles. So in this given ECG, P wave, QRS complex, P wave, QRS complex, P wave, QRS complex. For every P wave is followed by a QRS complex. And then the P wave duration is less than 0.12 seconds and the amplitude is no more than 0.2 millivolts. There is the characteristics of P wave, and these are the things you need to look when you are assessing for P waves. And then look at the QRS complex. The QRS complex is the major positive deflection, and it represents the timing and sequence of synchronized depolarization of the right and left ventricles. Normally, there is no QO in most of the ECG leads, and also you cannot see the total QRS complex. Most of the times you will end up seeing QS complexes. RS complexes are very, very common. And sometimes there can be physiological Q waves. Physiological Q waves may be usually observed in leads L1, AVL, V5 and V6, representing the septal depolarization in these leads. A physiological Q wave should meet the following criteria, otherwise it will become a pathological Q wave. It should be less than 0.04 seconds in width or less than 25% of the next R wave. That is a characteristic of the Q wave, physiological Q wave. R wave is a major positive deflection. It is negative in AVR along with other waves. R wave voltage is normally at least 5 millimeters in limb leads and exceeds 10 millimeters in precordial leads. Usually the R wave amplitude gradually increases from V1 to V6. That is called the progression of the R wave. If the progression of R wave is impeded, you should suspect ischemia. Next, the S wave is the negative deflection that follows the R wave. S wave magnitude is greater than R wave height in lead V1, and the S wave is smaller than R wave in lead V6. Next step is finding out the QRS duration. Normal QRS duration is 0.04 to 0.12 seconds, that is 1 to 3 boxes. Look for presence of a Q wave. Q wave is pathological if it is more than 1/3 or 25% of the following R wave. Look for R wave and SO morphology and amplitude. Next is interpretation of the T wave. The T wave is large rounded wave produced by rapid phase of ventricular depolarization. A wave is normally upright in most of the leads. It can be inverted in lead AVR, definitely inverted in lead AVR, along with the P wave and the QRS complex. It can also be inverted in lead V1 and occasionally in V2 and V3, especially so in females and children. T wave is taller in lead V6 than in lead V1. When assessing the T wave morphology, mainly you are concentrating on the T wave direction and the amplitude. Look for T wave amplitude. Normal does not exceed 0.5 millivolts in limb leads, 1.5 millivolts in precordial leads. Direction should be upright or can be inverted in few cases, as I told earlier. If you are seeing any inverted T wave which is deep and wide, that indicates an ischemic event. As you know, the next wave is the U wave. U wave is small rounded wave produced by slow and late repolarization of the intraventricular Purkinje system. Usually best appreciated in precordial leads V2 to V4. Normal U waves is upright and it is normally much smaller than the T wave which it follows. Next step, we have now entered into determining the intervals. One of the intervals you have already seen, the QRS duration. Next is the determination of PR interval. As you all know from the previous lectures, the PR interval represents the AV nodal delay, or the time taken for the impulse to traverse the atria, reach the atrioventricular node, the atrioventricular delay, and the time taken for it to reach the ventricles and start depolarizing the ventricles. That is the PR interval. PR interval is a measure of atrioventricular conduction time. Initiation of P wave to start of the QRS complex, as I told, shown in the picture. Start of P wave to the beginning of the QRS complex is taken as PR interval. Normal PR interval should be 0.12 to 0.2 seconds. If it is more than 0.2 seconds, it's said to be prolonged PR interval, which usually indicates AV conduction delays. Next is the QT interval and the corrected QT interval. QT interval denotes the total time duration of ventricular systole. It is measured starting from the point of QRS complex, yes, starting with the Q wave or the R wave to the end of T wave. Normal QT interval is in the range of 0.35 to 0.45 seconds. The QT interval is mostly dependent on the rate. So usually you take a corrected QT interval. Most commonly used formula for taking corrected QT interval is the Bézard's formula, which says corrected QT equal to the original QT interval divided by root of RR interval. That gives correction for the heart rate, which gives you an appropriate QT interval duration. Next is the PR interval, the portion of the baseline which intervenes between the termination of the P wave and the onset of QRS complex, same level as the main segment of the isoelectric line which intervenes between the T wave of one cycle and the P wave of the next cycle. So following with the segments, the PR segment, then you are going to look at the ST segment. The portion of the baseline which intervenes between the termination of the S wave and the onset of T wave is the ST segment. The beginning of ST segment is the junction point at the J point. Normally J point and ST segment should be in level with the isoelectric line, which is usually the PR segment. So when you start examining the ECG, you completed all your steps. You need to examine the leads in a specific order so that you won't miss any abnormality in any of the leads. So that the order should be start with the bipolar limb leads first. That is, start with the lead 1, 2, 3, and then proceeds with the unipolar limb leads AVL, AVF, AVR, and then examine the precardial leads in the same order, that is V1 to V6. This is the order you need to follow when you are interpreting the ECG. So I'll end the lecture by giving you some of the features of a normal ECG. You know, there should be regular rhythm, because SI node has one of the main functions of SI node is rhythmicity. It fires at regular intervals, so the impulses that are recorded in the ECG should be at regular intervals. PP interval should be equal and the RR interval should be equal. Then you call the ECG should to be a regular ECG. Heart rate, normal heart rate is 60 to 100. Below 60 you call it as bradycardia. Above 100 you call it as tachycardia. So the normal heart rate should fall somewhere between 60 to 100. There should be a P wave, and each P wave should be followed by a QRS complex. The PR interval should be within the normal range, that is 0.12 to 0.2 seconds. QRS duration should be less than 120 milliseconds. All the durations, voltages, intervals, and segments should be within normal range. So if you follow these steps in the same order without missing or skipping any step, most of the time, 99% of the time, you will arrive at the diagnosis. In the following lectures, we will be seeing about abnormalities of each of those parts. Thank you. Don't forget to subscribe and share the videos for wider dissemination. Thank you once again.